Hi class, welcome to Unit 3. This is a supplemental lecture in addition to the full-length recorded seminar I do for Unit 3. So I just wanted to take a few minutes to talk about some key assessments to help you understand about a focused cardiac assessment. So let's talk about some key points. So we learned ape to man. Maybe you learned that on where to auscultate anatomically for the different valves and heart sounds. This is a reminder of that ape to man pattern. You do need to know that. And then the other graphic on here is the cardiac blood flow, and the mnemonic is tissue paper my assets. And that's the actual order that the valves are in the heart. So just two different perspectives. Are we auscultating or are we talking anatomy? So when we auscultate, what we are listening for is an S1 and an S2, a lub and a dub. So S1, the AV valves close. Those are the tricuspid and mitral. With the S2, the semilunar valves close. That's the pulmonic and the aortic. We're also listening for extra sounds or a rushing sound. That's a murmur. A cardiac murmur is a rushing sound, and it's made as blood is moving through a narrow place, and that could be related to an incomplete closing of a valve, or it could be the regurgitation or the narrowing of a heart valve for something like stenosis. And something that's a risk factor for developing a murmur is rheumatic fever. So anytime you see rheumatic fever as a history on a patient's chart, you want to think, ooh, I should listen for a murmur on this patient because they're at an increased risk. So another thing that we assess is the carotids. And we do this to assess for bruits. Bruit is the sound that is made as blood is turbulently flowing through an artery. With the carotid, it's the artery that supplies the blood to the brain. And so a common reason why a patient would have a bruit would be because there's atherosclerotic buildup and or stenosis, and that puts them at a higher risk for a stroke. So if you're auscultating the carotid arteries and you hear a bruit, you need to report this to the healthcare provider immediately because they're probably going to have surgery to get those blood vessels opened up. All right. Touch and base on orthostatic hypotension. As you will learn in a minute, hopefully it's a refresher that basically every blood pressure medication and diuretic is at risk for causing orthostatic hypotension. So what is orthostatic hypotension? The textbook definition is it's a 20-point drop in systolic blood pressure when going from changing positions, either from supine to sitting or sitting to standing. Or it could be a 10-point drop in diastolic blood pressure, but usually we're most focused on the systolic. Typically what happens in orthostasis or orthostatic hypotension is that their heart rate will increase while their blood pressure goes down. And we would suspect orthostatic hypotension if a patient says, gosh, when I go to get up or move or stand up, I feel really lightheaded or dizzy. That's an indicator that we as nurses need to do the intervention of checking orthostatic blood pressures. And orthostatic blood pressures should be done first supine, then sitting, then standing. You should get blood pressure and pulse, and what you're looking for is that change in 20 for systolic BP and the pulse to go up. And that's what this picture shows. Okay, so this unit we also talk about cardiac tests, and a specific one is cardiac catheterization. So this is what we do when we suspect there is myocardial uh, damage or occluded coronary artery blood vessels. People have to be NPO for about 6 to 8 hours for solid foods, 4 hours for liquids before they can go to the cardiac cath lab. We will need to get a height and weight on our patients because we use this to calculate how much dye they can have. We're going to get baseline vital signs and assess and mark peripheral pulses. Our insertion site, where they're going to go in and thread up the catheter, has to be shaved and cleansed, and they're going to need at least one peripheral IV. So we're also going to verify that the consent is signed. We don't typically have patients sign consents for procedures because that's the physician's responsibility. So we would need to make sure it's been signed, but if it hasn't been signed, we'd call the doctor, say, hey, we don't have a signed consent. Can you come and take care of that? We will also verify that they don't have any shellfish or iodine allergies because they will be getting IV contrast. If your patient has low renal function, we may want to put a Foley catheter in them because the IV contrast puts them in an increased risk for acute renal failure. And so we're going to watch urine output very closely. All patients are going to have IV fluids hanging at least to TKO. We're going to have lab results back and on the chart. So that's going to be your cardiac markers, probably a CBC, clotting factors, and a metabolic panel. And then, like I mentioned, we're going to assess and mark the pulses so they can be easily reassessed after the procedure. So that's all getting them ready to go to the cath lab. Then they go out the door, they go to the cath lab, and then we get them back after their heart cath. So what do we need to do? Well, we need to assess and then act. What are we going to assess? We're going to assess vital signs, the insertion site. Specifically, we're assessing the insertion site or the access site for hematoma formation or active bleeding. And we do that very frequently at first. Usually it's every 30 minutes. And then we do that for like 2 hours, and then we taper it off of that. We are going to assess the pulses, especially on the side that they accessed and distally to that. We're going to assess the color and the temperature of the leg or arm that they gained access in. And remember, you always want to compare that bilaterally. That's how you really can pick up subtle changes. We're going to keep them on strict bed rest for about 6 to 8 hours. Usually they can turn from side to side, but the head of the bed needs to be less than 15 degrees. And strangely, we encourage fluids, which is uncomfortable because they either have to use a bedpan or pee in a urinal. But we encourage fluids because that helps get that IV contrast out. We're also going to assess them for hypersensitivity reactions to the dye, which could be things like nausea, vomiting, or rashes. And we're going to constantly assess if they're having any chest pain. Because if they have chest pain, that needs to be immediately reported to the healthcare provider, as well as any numbness, tingling, extremity changes, bleeding, or hematoma formation. And then the last thing is potential complication. A piece of plaque could break off and cause a stroke. So that's why we're going to assess for confusion, disorientation, slurring. All of those are neuro symptoms. So symptoms that something's going wrong in the brain and they need to be acted on immediately. So notify the physician. So quite a lot to remember and think about post-catheterization. And now let's talk about some medications. So diuretics. There are lots of different types of diuretics. All of them work to get rid of excess water and sodium through urine. They all work to decrease the workload of the heart because it decreases the circulating blood volume. They all increase urine output, which can also help with decreased renal function. For any diuretic, we need to be thinking, hey, we need to monitor I's and O's. With particularly the loop diuretics, we need to monitor potassium loss. With the potassium sparing diuretics, we also need to monitor potassium loss. We need to monitor their weight, their vital signs, hearing loss, that's closely related to Lasix. And we need to do some patient education. We need to teach patients to take these meds early in the day to reduce the risk of them getting up at the night to pee. They need to drink plenty of fluids. They need to rise slowly when changing positions. And for all diuretics except potassium sparing, like aldactone or spiroaldactone, we want them to eat high potassium foods. So then I want to just touch base on Lasix, also known as furosemide. Before we give Lasix, we should do an assessment of blood pressure and pulse. We should get a baseline weight. We should also take a look at renal function and potassium levels. And then we need to tell the patient to report any hearing problems or gout symptoms because Lasix can make gout worse. So then we go to vasodilators. These work to relax blood vessels, which increases the supply of blood and oxygen to the heart. Vasodilators are sometimes used by people that can't tolerate ACE inhibitors. Vasodilators can help with chest pain and lower blood pressure. These also can cause headache. And if nitroglycerin causes headache, we're going to treat it with acetaminophen. There are other vasodilators besides nitroglycerin that could be isosorbide or hydralazine as well. Those are both vasodilators. And with nitro, the big thing is how fast is it going to start working? And that comes down to, is it sublingual or is it ointment, a patch kind of thing? If it's sublingual or translingual, it's going to start working very fast. So you want to have them laying or sitting with the first dose. Nitrobid or nitro ointment, those are going to start working a little bit slower. And you're not going to see such an immediate change in blood pressure with that. Okay, so then we need to talk cardiac glycoside. And if you can think back from pharmacology, our good old friend digoxin. It is a med that is helpful in treating arrhythmias and heart failure. We use it specifically for atrial fibrillation or heart failure. How it helps is it inhibits the sodium and potassium pump, which suppresses AV node conduction. It also increases the force of heart contraction, and that's why it's helpful in heart failure. It does have an antidote, and that antidote is called Digibind. So when you see digoxin, I want you to think heart failure or atrial fibrillation. And I also want you to think that it's very sensitive to potassium levels. So we want to keep an eye on potassium levels because if they're out of range, specifically low, your patient's at an increased risk for adverse reaction to it. All right, so then we go to our old friend, the PRILs. PRIL, that is the ending for ACE inhibitors. ACE inhibitors are used to treat heart failure, hypertension. The long name is angiotensin converting enzyme inhibitor. And what it does is it lowers the level of angiotensin in the body, which dilates blood vessels, which in turn lowers blood pressure and blood flows easy. or easier, and the workload of the heart decreases. So ACE inhibitors end in PRIL. Key side effects: orthostatic hypotension and a dry, irritating cough. Those are the key ones that you should focus in on. Which brings us to our calcium channel blockers. So examples of calcium channel blockers: amlodipine, ditelazam, verapamil, and etc., etc. Calcium channel blockers interrupt calcium movement in the heart muscle and blood vessels, and that relaxes the blood vessels, slows the heart rate, and blood flows easier. So with these, the side effects you want to focus in is it's going to slow the heart rate, lower the blood pressure, and could cause a little GI distress. And then we get to our beta blockers. Those end in OLOL. And beta blockers work to block the effect of adrenaline on the beta receptor sites, and that blocks the impulse. And if you can think back from pharm, there's two types of beta cells: beta 1, beta 2. Beta 1 is in the heart, beta 2 is in the lungs. Beta blockers can be used to treat hypertension, chest pain, and arrhythmias. They are going to decrease the pulse rate, make it slower and less forceful. They're going to decrease cardiac output and decrease blood pressure. And so knowing this, those are also side effects of beta blockers. If your patient has a low pulse, like a 48, assess their meds list first. Are they taking a beta blocker, something that's going to slow the heart rate? And if your patient does have a slow heart rate, tell them not to strain when using the bathroom, because that's going to slow their heart rate even more and they could pass out on you. Okay, so common cardiac meds that you need to have at the forefront of your mind. Digoxin. I want you to think heart failure or atrial fib. It's not a first choice for atrial fib, though, because digoxin has a lot of interactions. Then we get to amiodarone. Amiodarone, think arrhythmias, and that includes ventricular arrhythmias. So your AFib, your A-flutter, and your ventricular arrhythmias. For Coumadin, I want you to think atrial fibrillation. Because of that increased coagulation of the blood, because it's not being pumped clean through, but we don't use Coumadin for heart failure. Heart failure patients are not at an increased risk for blood clots in the heart. Then we've got metoprolol, which is used for heart attacks, after heart attacks, hypertension, heart failure, and then less commonly it can be used as an antiarrhythmia. And then the last on the slide, verapamil. Verapamil is useful for hypertension, arrhythmias like supraventricular tachycardia, which means atrial fib and atrial flutter. Okay, so some priority labs that should be at the forefront of your mind. CKMB. That one will help us know if there is cardiac muscle damage, but it's not as good as a troponin. A troponin is very specific to myocardial damage alone. Then we've got our C-reactive protein. That is a great marker to tell us if there's inflammation in the body, and that's linked to heart disease. And then our last one, you probably already know this and don't need a reminder, but the BNP, that's your heart failure marker. So just some key labs to have at the forefront of your mind. And then just a send out from Nurse Kitty here. We're going to deck the hall with beta blockers. Oh well, oh well, oh well, oh well. Thank you so much for listening, and please let me know if you have any questions. Just send me an email.